Spinal Truth Show weekly podcast edition. I'm your host, Dr. Caleb Slater, here with Chris to provide some, what do you provide, Chris?
I don't know. I guess the everyman's kind of perspective.
To provide the everyman's perspective. Make sure to like and follow us on TikTok and Instagram. We are also on YouTube and Spotify for our podcast. Today's topic is the typical healthcare journey. What most people go through, what's wrong with it, what can be avoided, and I think this is going to ring true for a lot of people listening to this. So let's just kind of start. You wake up and you have some pain, right? Mm-hmm. You can't move your neck, you're pain in your low back, symptoms going down your legs, something. Maybe it happened after a slight trauma. You fell, the dog pulled you, you sneezed, you worked out a little too hard, but you woke up, you're in pain. And for most people, obviously there's going to be different paths, but we'll talk about the most common path is you go to your doctor, either urgent care or your family doctor. Yeah. A lot of people initially, they're a little freaked out. They think something's really wrong. They're picturing a blown out disc, they're picturing a tumor. So a lot of people are urgent care or the ER at first.
Sure. Yeah, it makes sense.
So you go to the urgent care or the ER, and they rule out the more nefarious things, which they should. And this is your space-occupying lesion like a tumor or a fracture if there's trauma. They rule out a cardiac event or a stroke or something like that. Or they see if you're having just a panic attack.
Yeah, I've had those experiences.
Yeah. Which all of this should be done. Okay, so far we're okay. All right. So you getting some serious symptoms ruled in or out, hopefully ruled out, is a good first step. But once they don't find anything, once they don't find a heart attack, once they don't find a stroke or a tumor or a fracture, once they don't find something that is clearly there and treatable, now they're just left with pain. And what they do for it next is honestly crap.
They, prescribe you something?
Most of the time it's a muscle relaxer that you're given or pain medication, maybe both.
And then they send you home.
And
then you're left with what do I do?
They give you kind of a tenuous diagnosis. They'll say it's a muscle spasm, or they'll say it's a disc issue or something like that, in a certain area of your spine. And let's just kind of to simplify it, most common is your neck or your low back. Yeah. Okay, so they'll say it's a lot of times they say it's a muscle spasm. And I can't tell you how many times I've had a patient and it was just a muscle spasm. It must be close to zero.
Really?
Yeah, and why did the muscle spasm in the first place? You have to ask that question too, right? If the muscle is truly spasming because you worked it out, you should know that. You should know that, hey, I ran an ultra marathon the other day, or I did a whole bunch of lifting that I haven't done in a while. And that's more of a common soreness type pain that you'd expect. So you go home, and now you're dealing with it, and they probably told you to go to your primary doctor. So you schedule for your primary doctor while taking these pills that just kind of numb you to your symptoms. You get in with your primary doctor. How long does it take you to get into a primary doctor?
Usually a couple weeks to months.
Yeah, let's say
maybe
2
less.
weeks. Let's say 2 weeks.
Yeah, depending on how urgent it is.
So you schedule it for 2 weeks. You have to find time in your work day or your work week. You have to take off of work, or the kids. You have to get the kids off to school first, or something, right? It's a pain in the ass, put it that way, just to go to a doctor's visit. And telehealth is, buffering a little bit, that these days you can do it from your comfort of your own home or anywhere that you're at, but it's not quite as good as being in person with somebody for the most part, right? So you go to your primary. They do pretty much the same thing that the urgent care did. They maybe draw some blood. They evaluate your vitals, and then they send you to a specialist.
Yeah, and it feels like a waste of time. I think a lot of times going to my general doctor for something that I feel like is niche or needs a specialist is a waste of time, and simply there because insurance requires you to get.
Well, and they're kind of the gatekeepers, right? And I get the idea of somebody steering you in the right direction, but if you have an orthopedic problem, it's a bone issue, you're going to go to an orthopedist, right? Right. If it's a nerve issue, you're going to go to a neurologist, and for the most part, anyway. But it's nice to have somebody managing your case, making sure that other people are doing the right thing,
Sure.
making sure you're giving you some suggestions. But there's a problem here too, because like what you said, you have to go to your primary because of insurance. The primary that you're going to might be, you have to go to that person because of your insurance. The person, and worst off, the person that they're going to recommend that you go to might be because of your insurance, and very likely is. Thank you for watching the Spinal Truth Show. I hope you're finding this information helpful. If you're out there and you're still in pain and you're looking for relief, we have some solutions for you. You can schedule a consult with me or a session, but if that's not in the budget, we also have some options that are self-guided at home. You can go to thespinaltruth.com. We have courses set up right now for arm pain as well as for neck pain. They are geared towards you. They are a 4-week course, 60 videos that are self-guided by an expert in the field that you can do from the comfort of your own home at your leisure. They will take you through step by step the typical approach that I take with patients. The expectation is that they will provide significant relief over these 4 weeks. So if you're looking for something better, something different because you're not finding the relief, go to thespinaltruth.com, sign up for one of these courses, and get the right treatment, see the difference.
But also your comment about like managing my diagnosis and my journey, my health journey, I don't feel like that fits my primary doctor. Unless you're like older or somebody who's constantly seeing them, they don't really know.
A lot of medications and stuff like that. Well, no, and I agree. And the other problem, other than already having a whittled down pool of providers that you can see or that they can refer you to, are same thing, the tests that they're able to order based off of your insurance, and more importantly, how much time they're able to spend with you based off of your insurance, right?
Yeah.
Because of insurances, we have gone from, the doctor comes to your house and while they're there, they take a look at some of your family members, right? We've gone from that to, if you're being conservative, 3 patients an hour for pretty much any physician.
Oh yeah, that's conservative, I think, for sure.
And if you extrapolate that out, 3 patients an hour times, an 8-hour day, 24, times 5 days a week, you're at 120. And then you do that for a month, let's just say, 20 some days in the month, work days.
Yeah.
You're somewhere around like 2,500 patients that month.
Yeah. In defense of these,
or sorry, 600 patients that month.
Yeah. But in defense of these like general practitioner doctors, I don't think they even want to be, they know they can't solve your back issue in a 15-minute visit, right?
See, I honestly don't know.
Okay.
I think most doctors believe in what they do.
It's not that I'm not saying they don't believe and they don't want to help. It's that like they're just not equipped for something that, even if I come with a back issue, I'm usually not going to expect a one visit, I'm better. This is like a journey that you have to.
Yeah, but I don't think it has to be. And,
Okay.
and that's part of the issue is I think you can go to somebody and see relief that visit, get good guidance.
Guidance for sure. Yeah.
Yeah.
I would, yeah.
So far their guidance is strongly rooted in medication and imaging. We've talked a lot on this channel that imaging is a lot more misleading and inaccurate than most people realize. It's taken in a position of comfort. It's a 2D representation of you in a moment. It's not with you being loaded or twisted, your spine being loaded or twisted or your joint. It's not. It's also, by the time you're 40, you're about 80% likely to have degenerative changes, which would be a herniated disc, spinal stenosis, facet arthritis, meniscus issues, rotator cuff issues, without any symptoms whatsoever. So the imaging and what it's saying and what you're taking from it it's miscorrelated to your symptoms because they don't have enough time to sit there and ask you about your symptoms.
Do you think a general doctor, but a lot of yours is based on 17 years of physical therapy experience, right? A general doctor, what do you think they're mostly seeing people for? Sick patients, diabetes, stuff like that, right?
Honestly, you probably said the two that I would have said.
Those are like probably 95% of the people they see.
Illness, diabetes, maybe some like blood pressure issues.
So to them, you go, oh, I'm having really hard pain in my back. Well, they're like, well, it could be this, or this. We need an image. Like they kick the can, but
which is fair.
Yeah.
But what they're going to do next is they're going to send you to a specialist.
Sure.
And you pretty much have one of 3 roads. you go to an orthopedist, or you go to a physical therapist, or you go to a chiropractor.
Okay.
Right? Like the most common approaches. Right? It's one of those three.
Okay.
Okay. If you go to an orthopedist, they're going to do the same thing that I just had a problem with that your primary did.
Right.
And they're going to do it probably a little bit quicker. Right?
Really?
Yeah. Have you ever been to an orthopedist?
No.
Oh man, they are in and out. They are.
Why is that?
They're busy. So let's take you down this journey again. We said it's about, you went to the ER, came home, scheduled an appointment with your primary. 2 weeks later, you're at your primary, send you to an orthopedist. The orthopedist is now, depending on the orthopedist, anywhere from, probably 3 to 4 weeks to closer to 6 to 8 weeks out.
Okay.
So they're busy.
And this whole time you're suffering.
Whole time you're suffering, you don't have any guidance whatsoever. You're, for the most part, I mean, you're waiting on somebody to tell you what is wrong and what to do. Yeah. Your orthopedist, I think they, more than anybody, cares about your imaging. They use your imaging to a fault. They've probably looked at your image before they've seen you. A lot of times they'll reorder an image, because they want their person doing it. And from my experience, that's what they go off of. They know what your diagnosis is, quote unquote, before they even meet you, and it's strongly based off of your imaging.
What do you think they? Why do they have such a focus on the imaging?
It's something concrete. It's something that they can see. It's something that they can point to and show the patient, whether or not the patient understands it or not. They can point on a screen and say, hey, this is you. This is your problem. This is what we're going to fix. And they're kind of mechanics. And I'm not belittling them at all. I'm just putting what their job is, and their job is to fix structural issues. They're structural engineers of the body. They're there to fix something.
It is, and you see it within the comments we get. How many people who say, "Hey doc, I'm having this. My X-ray says this. It's everyone. It's everybody.
Yeah. Just today, somebody said, "Yeah, I was told I have straight neck and actually a straight low back," and I'm like, "Yeah, you could just throw that out." And that's more more chiropractic speak, straight neck. But that means nothing to me. Yeah. Absolutely nothing. If you say I have a herniated disc, that really means nothing to me. I care about your symptoms, where they are, when they are, how they present, how you move, how you respond to certain positioning or movements or even treatment, because that matters more than your image. You can have a herniated disc and have no symptoms whatsoever.
Is there ever a moment that the symptoms don't matter more than an image or
trauma,
a blood test?
Trauma, or then you're talking infection,
trauma,
stuff like that,
like a cancer or something as well.
Okay. Right. Yeah. So then that's.
But that stuff would be ruled out if you go to the ER or if you get right.
Right. And that's kind of my point. The ER, between the ER and your primary, that should have been ruled out.
And once that stuff's all ruled out, it's basically all, what do the symptoms say?
Well, and when symptoms, it's imaging, right? Like for most doctors. So, and put it this way. So, let's say you go to the orthopedist, you spend your 5 minutes with them. Let's say they even look at your symptoms, okay, or they care more about your symptoms than your imaging. What's going to be their recommendation for treatment?
Surgery or injections?
Yeah, surgery or injections, right? Yeah. Maybe send you to physical therapy, okay? Those three, right? And most of the time, they're going to do injections first. The injections are going to be some form of cortisone and pain medication. It's an epidural or it's a facet injection. These injections do nothing to treat your underlying cause. They do nothing to explain the cause. They just numb you to your symptoms. So now you're numb to your symptoms, and now maybe they send you to physical therapy, but that's a pain in the ass for us because you're coming into physical therapy with a poor understanding or poor connection to your symptoms. So we're trying to see what's going on, and you're not able to tell us.
You're not able to tell us, and you have been convinced that this image says this, and that's where the problem is.
You've been told this image says this. You've been told that the injection or the medication that you're getting is treatment. And that's a big problem that I have, is that those are offered as treatments and they're not. They should be offered as Band-Aids. They should be, hey, look, I can make you feel good in the moment. And there's nothing wrong with that. There's nothing wrong with feeling good in the moment. It does get in the way of actually evaluating your condition. So I'd prefer that not happen before. But if, like, I was actually telling a patient the other day, I said, look, if I knew I was going on this trip and I was in pain, I would have no problem getting an injection before going on this trip to help me have a good time.
Yeah, I mean, numbing your symptoms to get through, everyone knows what that is.
I don't think they do.
Okay, if you put it in a hyperbolic sense of, hey, I have to drink because I'm sad, or I drink to get through something. Do you know what I mean? Like, that's not healthy. No one would say that's healthy. But it's similar in a sense where you were just numbing that pain, but not actually fixing the root cause. And so, how is that a solution?
Well, I agree with you, but based on a lot of the comments that we get, they're like, the treatment for plantar fasciitis is a cortisone injection. The treatment for a frozen shoulder is a cortisone injection. The treatment for back pain is facet or an epidural. And they're like, I'll get a lot of people that say, I get 2 to 3 epidurals a year, and that fixes me.
And then when you push back and say, well, maybe we check a part of your spine and we try some movements, they say, no.
Why push back? If you need 2 to 3 a year, you're not fixed.
Oh, I get that. I guess in some sense, the patient they think that this is their new life and this is the way they have to go on.
They accept it because they don't think other treatments are going to work. And here's where we need to be fair to the patient and the system, because I agree with them so I'm a physical therapist. I think most physical therapy approaches are ineffective.
Yeah.
Most of them are, and so to kind of break down what a normal physical therapy appointment is, for a lot of people, it's you go, you get evaluated, they hand you a exercise sheet, you go and do your exercises, and you do that 2 to 3 times a week for 4 to 6 weeks. And often you're seeing different people. You're not even sure who your therapist is. If they are a better clinic and they're doing more hands-on and one-on-one stuff, even that stuff they're doing is they're stretching you, which you can stretch yourself for the most part. They're doing trigger point relief, which is just passive. They're doing taping, which is just temporary. They're doing ultrasound or stim or hot pack, which is just making you feel good in the moment. Most of the time, or they're teaching you how to do core neutral strengthening, or with very little resistance and without movement. And again, if you said like, hey, I want to really strengthen my quad, but I don't want to move it and I don't want to use a lot of resistance, you'd say, well, you're not going to strengthen your quad. Right? But for whatever reason, this is the approach that we take for your spine, for your neck, for your low back, is we say very little resistance in a small range of movement.
It's hard from a patient's perspective because we're supposed to be trusting the experts, right?
Yeah, and you know what? To be fair, I have, obviously I'm in the healthcare industry. I've had, like what you said, 17 years. I'm an expert in my field, but it took me probably a solid 12 years to start going, hey, this isn't working.
Yeah.
And it took me 12 years of, that's why I kept getting other certifications. I got my orthopedic certification thinking, all right, this will help me get patients better.
Right.
I got my Maitland certification, this will help me get patients better. My McKenzie certification, my fellowship, I kept doing that saying like, all right, this is going to be the answer. And it kept, small glimpses here and there, but it wasn't the answer. And it took me to probably about 12 years to say, hey, I think we're doing this wrong just globally. The entire medical field is doing this wrong. Hey, just a quick break here and then we'll get back to the show. If you're out there and you want to see if this is the right approach for you, you can schedule a consult or a session with me. Go to thespinaltruth.com, at least set up a consult. Within 30 minutes, I will listen to your symptoms. I will go over your history. I'll go over what the approach I would take for you and the results that I would expect. My goal is to save you from continued pain, failed treatments, and prevent you from getting surgery. So go to thespinaltruth.com, set up a consult, and let me go over your symptoms. Now let's get back to the show.
We go to PT.
We go to PT, we talked about that. PT has its limitations. I'm a physical therapist, my wife's a physical therapist, and I'm generally down on the typical physical therapy approach.
Yeah.
You could also go to a chiropractor. Chiropractors have their benefits. But for the most part, again, to boil down a typical chiropractic treatment is you go and you get a hot pack and some stim. They use a machine on you like their activator or a Theragun. They crack your back or somewhere, they crack a few joints and you're out.
Do you think people think that chiropractors fix them?
Yes, and I wouldn't say that chiropractors don't, but in general, they make you feel good in the moment, but you keep needing to go back.
Right.
Because the treatment that I outlined, the hot pack and stim, a little bit of a Theragun or something, traction, and then cracking you, that makes you feel better, but that does nothing to promote range, and that does absolutely nothing to promote strength and stability in that range, which are really the two things that you need.
Yeah, you're going to go back to doing the exact same lifestyle things you were doing and put your back or whatever in the exact same position.
And you're kind of using the chiropractor as, instead of doing the stuff that's good for you, you're letting somebody else do something for you. And you're like, oh, the chiropractor, well, I'll just keep going, once a week for the rest of my life.
Yeah.
And my same response would be like, well, then they didn't fix you. If I see you, I hate seeing people more than honestly, 7 to 10 visits. Because I pride myself in how quick I can, or how few visits I can get people better for a lot of conditions. After that, I starts eating at me a little bit, and I'm like, what's going on? What are we doing wrong?
And you're talking about I know there's some that the conditions have to be worked through, so you're solving multiple layers.
There's some people out there that they need a lot of treatment over time, and absolutely. But I typically deal with chronic pain patients that they've been to physical therapy, maybe many different physical therapists or chiropractors, many different orthopedists or neurologists. They've had many different types of injections and medications or even surgeries.
Well, and speaking to that, I think the problem with, hey, okay, I just go to the chiropractor every week or every other week. I've seen this with my dad where, I go to the chiropractor every other week. But over the years, his condition worsens.
Right.
And that's not fixing it. And maybe it's still kind of making him feel a little bit better, but he's getting worse overall.
And this is my problem, is that we're spending a lot of our time and energy, we're wasting a lot of our time and energy and money on things that just help in the moment or are just a Band-Aid and numbing you to your symptoms.
Yeah.
And again, there's nothing wrong with any of that, but you should as well be doing something that is ultimately going to lead to lasting results, and we rarely are. Rarely.
Yeah.
So you go to the ortho, right? They maybe do an injection, maybe send you to physical therapy. To be fair, most of the time, physical therapy didn't work. You're still in pain. You go back to the ortho. You get more injections, okay? And now they start setting the groundwork for future treatments, okay? And future treatments, when it comes to, we'll just stick with the spine, it's going to be some form of a surgery that's like a laminectomy, or a discectomy, or a fusion. They're gonna do that, and now you're gonna go to physical therapy, or you're gonna recover for months to years, right? You're probably gonna have some more injections later on, because most of the time, even with fusions, symptoms return within a few years. And now they need to fuse a level above or below. During that time, you've had more cortisone injections. During that time, they also might be doing a procedure called a nerve ablation or a rhizotomy. Same thing, where they chemically or thermally destroy the sensory portion of the nerve, which is basically them saying, hey, you're in pain, you've continued to be in pain, the treatments of the injections and physical therapy haven't worked, so we need to destroy this nerve so that way you don't feel your pain.
Yeah.
Does that sound like treatment to you?
No, although I have had it done.
Okay. Where'd you have it done?
Well, I don't know if it's the same thing. I had ingrown toenails, and they destroyed the nerves around the sides of my toes.
That might be a little different. Does that?
Okay.
So I'm not familiar. Does that stopped the
ingrown
stopped
toenails.
it from growing?
Yeah, and they were awful. They just kept coming.
Yeah,
so.
that's a little different.
Yeah, but it's the same kind of in theory.
This would
right?
this would be like destroying the nerve. So now when you have the ingrown toenail, you don't feel it.
But it's still there.
But it's still there.
Yeah, exactly.
Which that'd be like, hey, this isn't good.
Yeah, and is that explain when you go to get that done that, hey, you actually still have the problem, you just won't feel it right now?
I'm going to say no. That's a great question for the listeners.
I doubt it.
If you've had a nerve ablation, was it explained to you that that's not fixing your problem?
Yeah, because how was that? That would be a terrible sales tactic, right?
Well, yeah. Right. Like, we're going to destroy. If I was as blunt it would be saying, hey, we have no idea what's going on, but I know how you're feeling it, so I can destroy that for you.
Hey, this doesn't work, but you won't know it anymore.
Right, but you won't know it anymore. Yeah, no, you're right. So probably not. And there's a ton of people have this procedure. Like it is relatively
But I
common.
understand it. It's like just something to get me out of the pain.
And again, absolutely, I understand being in pain is awful. I understand wanting to get out of it. My problem is the way it's presented. My problem is, that the treatments that are offered to you that allow you to get to that point where you're at a loss are so poor that they often lead to this. And that's the whole point of this, podcast today, is that this isn't an exception. This is the norm for people out there listening to this. And we're maybe talking over the course of, I don't know, anywhere from 1 to 5 years that you're going through all this, but it's as common.
Outside of a traumatic event to your body, is there a time where it makes sense to do something like that? Like, is that ever a real solution to something?
Only when you're literally using it for what it is. When you're saying, hey, you are in, intractable pain, we can't
fix it.
So the best way that we can fix it is to destroy it.
But when can't we fix it?
What do you mean, when can't we fix it?
So is there a point where you would see somebody, or like where you like, we can't fix your problem with movements or?
Yes, but if that's the case, then most of the time, then a surgery like a kyphoplasty or a fusion or a laminectomy or something like that would then be the next treatment, not the nerve ablation.
Would you say that those people, though, are, like, the amount of surgeries happening to the back, how often do you think those would be actually necessary?
5% of the time.
From what they are now?
Yeah.
Yeah, okay. That's what I thought. That's kind of where my question was going.
Yeah, 5%.
Because it seems so common based on the comments we get.
So to put it the other way, 95% of the time, those surgeries can be avoided. They're unnecessary.
Yeah.
Well, and so you had the nerve ablation after you had the procedure, and now maybe you had another fusion down the line. Now you're still in pain, so we're still not quite done, almost done. The final thing that they'll throw at you is a dorsal column stimulator. So it's an implanted device. It's basically an implanted TENS unit. It does the same thing as the nerve ablation for the most part, is it sends an electrical signal that blocks the brain's perception of pain in that area. They never work. I shouldn't say never, but almost never.
And they don't work permanently if they do, right?
Most of the time you get used to, and this is something I talk about in my book, is you get used to stimulus. Like when you put your shirt on this morning, initially you felt your shirt, you smelled your shirt, right? Hopefully it was clean. It doesn't look clean, but that's okay.
It actually was clean, but I was playing with the cat this
your
morning.
senses are aware of it, right?
Yeah.
But after a short period of time, your body now perceives that as normal. Yeah. You don't smell it anymore. You don't feel it anymore, right?
Yeah.
Same thing when it comes to a lot of these treatments like this TENS unit. At a certain point, your body gets used to that level of pain, that level of stimulus, and now all of a sudden it stops working, and you turn it up a little bit, and maybe it works a little bit more.
Until you max it out.
Until you max it out, which most people do, and then eventually it's just not working, and they just shut it off.
So they do all that. I don't know if this is still a norm, but at what point do they start prescribing heavy drugs?
Right about after that.
Okay.
Yeah, and maybe a little bit before that, and some of this depends on the patient. If the patient's pushing for it a little bit, some of it depends on the doctor. But somewhere in between, somewhere around that time is when you start getting the heavier drugs, because now they've tried everything, it's not working, and now they're just going to manage it with medication.
And what do those drugs look like? Do they still do oxy?
Yeah, oxy. I mean, and this isn't my world, but Vicodin, oxy, fentanyl, fentanyl patches, stuff like that.
Yeah, and that's, my dad's been through all that.
Fentanyl lollipops?
I don't know about that. But the thing was, like, I just remember him suffering with all the back stuff, having the surgeries, all this stuff. He had the thing you go in and stretch your back.
The inversion table.
All that stuff. And then eventually leading to the oxy and all the patches. And it's just the change in, like, his whole persona, his whole person from chronic use of these pain management drugs.
Yeah, and from being in chronic pain, like the pain wears on you. It becomes heavy. You know, it becomes the first thing you think about in the morning. It becomes the first thing.
Life.
Yeah, when somebody says, "Hey, do you want to go out shopping?" The first thing you think of is, my back hurts.
Can't drive.
Right. Like,
my back hurts.
Where, am I going to be able to sit down if I need to? How long are we going to stand for? You know, stuff like that.
Crippling.
Yeah. Where now you start, like, the first thing you should think, oh, that's fun. You know, it sounds like a good time. And so it does become depressing, and it becomes a burden psychologically and physically.
Yeah.
And also, too, during that time, like, you're not moving as much. The lack of movement creates lack of strength, lack of blood flow, lack of health, lack of vitality, right? And
everything.
It snowballs into itself. And I'm sure you've seen this. And with your father, like what you're saying, and this isn't overnight. This is over years, and it's a slow process. But now being in this field for this long and dealing with a lot of these chronic patients, you can come to me, and on day one, I can see your journey. You know, I can see you 10, 15 years out from now, and it's sad for the most part, right? Like, it's sad thinking it, or maybe for me on the lighter side of things, I'm proud of thinking how much I prevented you from.
Yeah.
You know, and I kind of wish that we could see both patients, you know, like you getting the treatment right away and you going the normal path.
Seeing that same patient through both the journeys. Yeah, I hear you.
But apparently that, you know, it's not possible.
We'll see where AI gets us.
Yeah, it's true, right?
Honestly.
So you asked a question about, all right, so that's the typical approach. So what should be the approach? I'm still fine with you wake up in pain and you're scared. I'm still fine with you getting evaluated at the ER or the hospital or your primary doctor, you know, somebody to rule out the nefarious things. Great. Once that's ruled out, now you should see somebody that is going to listen to your symptoms, that's going to take time and listen to where your symptoms are, how they behave. Is it numbness, tingling, pain? Is it all the time? Is it intermittent? Is it when you're sitting versus walking versus sleeping? How intense is it? Is it on both sides? You know, what have you done in the past? Have you ever had anything like this in the past? Or what are your previous history of pain or where it was, or, you know, orthopedic conditions? Then they should look at how you move. Are you stiff? Are you limited? Is your pain in a certain plane of movement or a certain position? Then what I do is then I press on the levels of the spine and I see if there's stiffness or tenderness, right? Then after that, I take patients through movements targeted at an area of their spine that we think is the cause, to take pressure off the nerve, to move the spine, to contract the muscles in that area in a range that would make them stay better. And then finally, we reevaluate their movements and we see if there's a change, if there's less pain, if there's less stiffness, if there's more range of motion. That tells me that we're on the right track. That's done over the course of about an hour. That takes about, you know, if I did it quickly without a lot of explaining what I'm doing, maybe 30, 35 minutes, but to explain to the patient what to expect, what to feel, stuff like that, that takes another 20 minutes or so.
Yeah. And then 2 weeks till you see them again, and during that time,
a week or two. So I normally like to see patients for the first few weeks once a week.
Yeah.
I give them 1 to 2 things to do at home during that time. I tell them what to expect. When they come back, then I evaluate their progress. If they're on the right track, we progress their exercise. Maybe we add something else, or we progress the intensity or duration or difficulty, resistance of the exercise that they have, or the movement that they have. But yeah, I don't want to wait too long to see them again. And that's the other thing that we didn't really mention, is that most of these people, if you are going to see them again, your primary doctor, your orthopedic doctor, your neurologist, if you are going to see them again, it's weeks to months until you see them again. And during that time, they've seen a significant amount of new, different faces, and you're lost in the shuffle.
Well, even if you're not seeing them again within that couple weeks or whatever, if they aren't seeing the movements making a change or seeing results, then that speaks to that isn't the right area that they should be targeting, or what? Yeah,
so let's say a patient comes back in a week or two and we're not seeing a lot of changes. Now we're troubleshooting, you know?
Yeah.
Now so my first thought is,
did you do
the patient did it wrong, right?
Yeah,
like,
either did it wrong.
Did you do them as much as I told you? Did you do them the right way? So we go through that. Most of the time that's the case. every once in a while, we picked the wrong area or we picked the wrong movement for it. So we just readjust.
Yeah.
But you're still working, you're still working to solve the underlying problem.
Yeah. I mean, we started making these courses because we're trying to get the message out there in a way, because you can't see 1 million patients a day. But
don't tell me what I can't do.
Well, okay, sorry. But within that, that's the whole, I think the empowering thing is for the people to be able to understand what's going on and kind of empower themselves in this.
The biggest thing that I do that I think patients appreciate is I explain so much of what I think is going on, what they expect to feel, what they shouldn't be expecting to feel, and if they do, what to do, how long this should take, what the progression looks like, how long they have to do these exercises for, why they're doing them.
Yeah.
By the time I'm done with an evaluation, I'm talking about as much as we're talking on this podcast. I am just talking.
Yeah. Well, and I mean, that was like the point of the course is like, you go through that course, you see the improvement, and now you know what's happening, and you know when you start feeling these symptoms again, if you're not doing your things, if you've been doing repetitive actions and you're feeling it again, you know how to treat it.
You know how to treat it. Yeah, you know how to treat yourself. You know what to correlate to what's producing your symptoms. Exactly. Yeah. And I really think that's invaluable. But again, it takes an hour.
Yeah.
So at the end of the day, you need to find somebody that has the time to give to you, to properly assess you, to properly go through what to expect, right? And unfortunately, I would say most people that take insurance don't have an hour to spend with you, because insurances have made cuts over the years, and those cuts lead to changes in the healthcare industry. And those changes typically mean seeing more patients and providing less treatment in a short period of time.
Yeah, and I don't want to be conspiracy minded, but you give me an injection or you give me a medication, that means I'm guaranteed to see you again.
Yeah, and it's easier to bill for, and it's significantly more lucrative.
Yeah, exactly.
Yeah.
But at the patient's health cost.
And I think a lot of people don't realize this. And maybe, I think a lot of people do. I do think the pendulum is swinging back a little bit, where we are starting to say no to medications and injections more so. Because for a long time, and this is, maybe in like the 70s, and I think I wrote this in the book, is like we took kind of a hard right to, we want a pill or an injection or a medicine.
Thing.
We want, and I get that, and I do too. If you could give me a pill that makes me taller, stronger, in less pain, healthier, whatever, sign me up. And I went that route for myself, and I've seen patients go that route, but I haven't seen it be fruitful. I haven't seen people say, hey, I absolutely took this medication. It solved my underlying problem. I am now better. I don't need it anymore.
I think in general, maybe there's more of a cultural shift. It does seem like in the 90s and the 2000s and stuff, it was all about convenience. And now we're kind of maybe culturally shifting a little bit further from that, because this approach does require the patient to do some work.
Requires some work, absolutely. Yeah. No, and you have to present it that way too. Yeah. You have to say, like, look, this, again, it isn't a quick fix. For the most part, I expect to see changes within the first visit. When somebody sees me, I expect to see changes. Now, that doesn't mean you're 100% better, but changes.
No.
But to get 100% better, for most people, and again, I'm treating chronic conditions. Mm-hmm. For most people, it's them being relatively consistent with these movements over somewhere between 6 to 12 weeks, depending on how long it's been going on for, depending on what their level of getting back to is,
It's crazy, like how that's so similar to like working out, like you want to improve your.
Well, and that's I actually tell that to patients, because we want to get you to the point where you are better, where you don't need to do this anymore. And to get you to that point, it takes remodeling tissue. And remodeling tissue takes somewhere around 8 to 10 weeks. Like if you want to work out, and I use this analogy for patients, like if you go to the gym, for the first 2 to 3 weeks, you're just trying to get back into things. You're real sore. You can't really up your reps or your weight. But then you start getting used to it. You're not as sore. You have a little bit more energy. Now you can up your reps, your weight. You can add more exercises, and you don't feel that recourse.
Yep.
But 3-4 weeks in, if you went and you took like a 2-week vacation and you didn't do anything, you're going to lose all your gains.
Yeah.
Every gain that you had. But if you stuck that out for 8 to 10, 12 weeks, and now you went on that 2-week vacation, you'll lose some, but you've created muscle change. You've created change in the tissue. You won't lose everything.
Yeah, it's hard forming that habit with diet, exercise, whatever. This is the same thing. It's getting into doing those movements.
I try to make it easy, and that's why I give patients 1, maybe 2 movements at a time to do. Let them get used to it, don't overburden them. And I really try to cap it out at like 4 or 5 movements for a problem, you know, because I'd rather you focus on the 4 or 5 things that are the absolute best for you than add a bunch of extra stuff just to add. And honestly, like that was a hard thing for me to get away from because it's so common in my area, because you want to provide value to the patient, right?
Yeah.
And you think that adding more exercises, more movements is providing value, but really you're diluting away from the thing that's actually helping, and you're getting in the way of your evaluation, because what's making you better? What's making the patient better? What's making them worse? Right. If you have 20 things, you're not quite sure why. If you have 4, you get a pretty good idea.
Now, how can you do this in a telehealth setting without touching the patient?
I can do everything that I talked about in a telehealth setting except for touching the vertebrae, like putting pressure on the spine. Most of the time, because I've been doing this for so long, it's not needed.
Yeah.
Every once in a while, it is helpful.
Yeah.
And it really only I need it on the first visit.
And that's just for you to know, to verify 100%.
It helps me confirm.
Yeah.
And it also, too, it helps the patient. So many people don't realize it. I just had a guy here yesterday, I think it was, came in from a different state. He's had, Crohn's symptoms for a long time now. He's had a history of back pain and plantar fasciitis, but he didn't realize how bad his back was. And for the most part, he didn't have back pain. For the most of the time throughout the day, throughout the week, he doesn't have back pain. Most people don't realize that they don't need back pain to have a back problem, and most people don't realize how bad their back is. When I had this guy down on the table, I'm putting a thumb's worth of pressure on areas of his spine, and he's writhing in pain. And you would think that you leaning against this chair, you sleeping, you moving around would cause that same sensation, and it just doesn't. Again, you get used to certain stimulus, but direct pressure on a small area caused this guy to jump off the table. And it was helpful for me, but it's also helpful for him to see how involved his issue was. His wife was sitting right there, and I'm like, look, I'm barely pressing, and he's wriggling around.
So when you're pressing, is it like a disc herniation, or what are you pressing on exactly?
Yeah, so you're pressing on the vertebrae. Okay. So you're pressing on the bony prominence, like the spinous process, or you're a little bit more on the facets, which are kind of like shingles on the sides of your spine.
Yeah.
You're moving them. Moving them moves everything.
Gotcha.
So I'm really just assessing for stiffness, because it should move, within a certain degree of normality based on your age, gender, size, right? And what spinal level. And then I'm also assessing primarily pain, how tender it is. Because if I move the vertebrae at all, you're moving the disc, then you're putting pressure on the nerve, you're moving the capsule, you're moving the fascia, whatever, but you're moving that vertebrae.
And the reason it would hurt is because it's not being...
Because there's a problem there.
Okay.
Yeah, because there's a problem. And again, like your body gets used to compensating,
Gotcha.
Which would be spasming around that area to protect it, to not let it move, which would be moving levels above and below. Like instead of, if I turn my head to the left, I could turn my body to the left so I don't turn my neck. And a lot of people do that, and they do it kind of unconsciously. They don't realize it, or subconsciously.
I mean, I just recently had that little bout where I woke up and my neck, I couldn't, and I just naturally, like it's not even, It wasn't even a thought.
And if that goes unchecked for a while, untreated, that becomes you. That becomes your new norm.
Yeah. And luckily, like I knew based on things we shot, like a couple things to try, and it was like a day. I was like, all right.
Well, look at that.
Good, yeah.
Like a testimonial for
exactly.
For this.
It was crazy.
And that should be the approach. And it's so frustrating seeing people go through this weeks, months, or years, decades of symptoms that you're like, fuck, if you just had the right approach at the beginning, this is treatable. I tell everybody, I'm like, hey, look, get in as soon as possible. The sooner I see you, the better. But unfortunately, because I don't take insurance and because I'm saying something different, I tend to be the last stop.
Yeah.
But yeah, getting it right away, it's so easy.
Yeah, because of centralization and peripheral.
The problem.
But
the problem
it worsens over time.
It worsens over time. And people start chasing symptoms. Your neck pain turns to shoulder pain, so now you get your shoulder treated. That doesn't really get treated. The underlying cause didn't, because it was your neck, and now it's your elbow, right?
Yep, now
and then it's your wrist.
Tunnel,
then it's your carpal tunnel,
Yeah.
and then finally somebody says, "Hey, this was all one problem," and the first person that evaluated your neck didn't do the right treatment. And now it's a little harder because it's progressed over time. The nerves, the muscles, tendons, they've deteriorated a little bit.
Yep.
You're stiffer, you're in more pain, you're pissed off because you spent time, money, and effort treating the wrong things, maybe even had surgery on the wrong things.
So is it the longer the problem progresses, the longer the treatment kind of takes?
It's not a one-to-one.
But okay.
But often.
Often, yeah.
Yeah. You could come to me and it's 12 years of pain and symptoms. I still expect to see improvements on the first session. But again, it depends, because you can have just some pressure on the nerve and it's been causing pain for 12 years. And as soon as you take that pressure off, you're good to go.
Yeah.
You can have a lot of pressure on that nerve. It's caused numbness and weakness over the years. You take that pressure off, you need that nerve to recover, to heal, and you need to strengthen that area.
Right. And one thing that I think is really important that you do when you see a patient, but also what we do in our course, is we make sure that you are logging the information of where the pain was, your symptoms, and your movements, so that after you do some of these exercises and movements, you see that there was a change. Because how many times have you seen people where they said they had an issue, you helped them, and then they said they didn't have the issue?
Oh, a ton. And
it's
I even tell patients,
Yeah.
I use it as a joke because it's happened so much. Like on the first visit, they're like, I can't drive for more than 10 minutes. It's just excruciating.
Yeah.
And then 4 weeks down the line, I'm asking them, and I use.
How's driving?
Yeah, how's driving? Like, driving, I never had a problem driving. And you're like, no, you did. I wrote it down,
You said you did, yeah.
Wrote it down. I wouldn't write this,
Yeah.
otherwise. But again, you forget. You become your new normal.
Yeah.
And you're right. So like one of the big things is having that baseline and then comparing to it, every week, every other week.
Yeah.
Because if you can see those changes, that helps you
know what's working and what's
helps
not.
you know what's working. Yeah. And part of this, especially because it's 3 to 4 weeks to like really make a significant 50% or more difference. You need a little bit of that along the way, like, oh yeah, this is working. So that way you stick with it.
Yeah, for sure. And I think also when you're talking about seeing a patient in their first session, seeing even a little bit of improvement, I think that's super motivating.
Yeah.
Especially if you've been stuck for years with something. So.
And again, it's my expectation.
Yeah.
And I think it should be the expectation of the medical field. I think we need to change. We need to adopt a different approach, and hopefully I'm a part of that process.
Exactly.
Well, that's probably a good place to stop.
I think
there.
so.
Yeah,
I think it was good.
So that's our show. If you have any questions, you can reach out to us at info@thespinaltruth.com. If you would like a session, either a consult or a session, you can go to thespinaltruth.com and set that up. Make sure to like and follow us. Again, we are on Instagram and TikTok, and we are also on Spotify and YouTube. Stay tuned for next week.